Hello and welcome back to the Deep Dive. Today, we are abandoning the abstract and the theoretical. We're going straight into the trenches.
We certainly are.
If you're listening to this, I'm going to make a few assumptions about you. You are likely a postgraduate student, an exam candidate, specifically preparing for the MD anesthesiology exams. Perhaps, specifically looking at the Gujarat University pattern or the DNB board exams.
You're tired.
You are tired. You're caffeinated. You're probably surrounded by a fortress of books. Your Miller, your Morgan and Mikhail, your Yao and Artuzio.
Yeah.
And you are probably terrified of one specific thing.
The viva voce.
The viva voce.
The final hurdle, the long case. The table viva, where you have to defend your physiology. It's a rite of passage for every anesthesiologist.
Exactly. So we're doing a final coaching session today.
Yeah.
I want you to imagine the expert here isn't just a podcaster, but your senior MD anesthesia faculty sitting across the table in the seminar room 1 week before the exam.
No pressure.
No pressure at all. We aren't just chatting. We are structuring answers. We are converting the dense text of Miller into exam gold.
That is the goal. We really need to make sure that you can answer the toughest questions they're going to throw at you on this topic.
And the topic we're tackling is a beast. It's the topic examiners love because if you don't know your physiology, your physics, and your pharmacology, you will get exposed immediately.
Oh, instantly.
We are talking about mechanical circulatory support, specifically the intra-aortic balloon pump, the IABP, and extracorporeal membrane oxygenation ECMO.
These are the heavy hitters. In the exam, these topics test your ability to integrate basic sciences with, real-world critical care management. You can't bluff your way through an IABP waveform or an ECMO circuit diagram.
No way.
You either know it or you don't.
So let's dive into Section 1, Introduction. Why are we even talking about this? What's the role of mechanical circulatory support in the modern context?
Well, historically, if a patient's heart failed, say, after a massive heart attack, and you hit the pharmacological ceiling.
Meaning you're on max doses of adrenaline, noradrenaline.
Max everything. That was it. The mortality was effectively 100%. But modern anesthesia and ICU care are defined by the ability to bridge a patient.
Bridging. That has to be the key word for the introduction paragraph of a long answer.
Absolutely. Mechanical circulatory support, or MCS, bridges a patient with refractory heart or lung failure to one of 3 destinations. You should list these in your answer.
Okay, what are they?
Number 1, bridge to recovery. The organ rests, the stunning resolves, and hopefully the heart heals.
Okay.
Number 2, bridge to transplant. We keep the patient alive, keep the organs perfused until a donor organ is found.
Right.
Number 3, bridge to destination. This is more relevant for long-term VADs, ventricular assist devices, but it's part of the whole spectrum of care.
And why is this an anesthesia topic? I mean, why isn't this just for the cardiac surgeons or the intensivists?
Because the anesthesiologist is central to the entire process. We're often the ones managing the patient during the insertion in the cath lab or the OT. We manage the T, the transesophageal echo, to guide the cannula. We manage the transport of these incredibly unstable patients. And most importantly, we manage the complications in the ICU. We're there from start to finish.
Looking at the question patterns from the DNB questions topic-wise source we have, this comes up constantly. It's not a fringe topic.
Not at all. You need to be ready for the long question, which is usually 20 marks. Something like, describe the physiology and anesthetic management of a patient on IABP.
Or a short note.
Or you might get short notes. Indications and contraindications of IABP, or differences between VA and VV ECMO, things like that.
And the Viva, what's the trap there?
The Viva is where they catch you on the practicals, identifying the catheter tick on an X-ray, interpreting the pressure waveform, specifically the timing errors, or explaining why the patient's right hand is blue while their left foot is pink on ECMO.
We will definitely get to that blue hand, pink foot mystery later. That sounds like a classic Viva question.
It is.
But let's start with the bread and butter, the intra-aortic balloon pump. Section 2. Definition and basic principle. If I'm writing an answer, I need a crisp definition. What is the elevator pitch?
If you are writing this, start with this sentence. The IABP is an intra-aortic counterpulsation device. That is the key phrase.
Counterpulsation.
You have to use it. It consists of a dual lumen catheter with a sort of sausage-shaped balloon, usually made of polyethylene, with a capacity of 30 to 50 milliliters, and it's inserted into the descending thoracic aorta.
Okay, counterpulsation. That sounds fancy. Unpack that for the student who is stressed out and just needs to understand the core idea.
It's simpler than it sounds. It basically means the device pumps against or opposite to the cardiac cycle. When the heart beats, which is systole, the device deflates and creates a vacuum.
Okay.
When the heart rests diastole, the device inflates and pumps. It works in the exact inverse of the native heart.
Now, anatomy is crucial for the diagram you will draw, so where exactly does this balloon sit?
And precision matters here. You have to be specific in your answer. The tip of the balloon must lie just distal to the origin of the left subclavian artery.
How far distal?
Usually about 2 centimeters distal. And the proximal end, which is physically the bottom of the balloon, should be positioned above the origin of the renal arteries.
So why that specific zone? Why 2 centimeters? What happens if you get it wrong?
Well, think about the consequences of missing. If you're too high, you occlude the left subclavian. You cut off blood flow to the left arm, leading to ischemia.
That's bad.
But far worse, you might occlude the left vertebral artery, which comes off the subclavian, and that compromises blood flow to the posterior brain circulation.
A stroke.
A stroke. And if you're too low, you cover the renal arteries. You turn a cardiac failure patient into a renal failure patient instantly. So the placement is non-negotiable.
And what's inside the balloon? Is it air? Saline?
It's helium.
Why helium? This is a classic Viva question. Why not air? Why not oxygen?
This comes down to physics, specifically density and diffusion. First, density. Helium is an incredibly low-density gas. We need this balloon to inflate and deflate extremely rapidly, in milliseconds, to match heart rates of 100, 110, 120 beats per minute.
Right, it has to keep up.
It has to keep up. A low-density gas creates laminar flow through that long, narrow catheter tubing. If you used air, which is heavier, the flow would be turbulent, the resistance would be high, and the balloon would be sluggish. It wouldn't catch the dicrotic notch in time.
And the second reason, you said there were two.
Safety. If the balloon ruptures, which is a known, though rare, complication, helium is absorbed into the blood much faster than air because of its low solubility coefficient. This reduces the risk of a catastrophic gas embolus.
So a big air bubble in the aorta would be lethal.
An air embolus of 40 cc in the aorta would be instantly fatal. A helium embolus is slightly more forgiving, though still incredibly dangerous.
Okay, so we have a helium balloon in the aorta. The core principle is counterpulsation. Talk to me about timing. You said it was sluggish if it wasn't helium.
Timing is the most critical concept for the exam paper. You must get this right. Inflation must be triggered at the dicrotic notch on the aortic pressure waveform.
And what does that correspond to anatomically?
Anatomically, this corresponds to the closure of the aortic valve. The heart has finished ejecting, the valve snaps shut, and then, in that instant, the balloon inflates.
Not before.
Not a millisecond before.
And deflation.
Deflation is triggered immediately before systole. Specifically, it must happen during the phase of isovolumetric contraction, just before the aortic valve opens. The balloon must be fully collapsed before the heart tries to eject blood.
Okay, inflation at the dicrotic notch, deflation before systole. Let's move to section 3 and unpack the physiology. This is the exam gold. If you get a 20 marker, this is where you're going to score the majority of your points.
It is. And when you write this answer, you need to break it down into 2 key headers. This shows the examiner you understand the logic, diastolic augmentation, and systolic unloading. This framework directly addresses the supply versus demand equation of the heart.
Perfect. Let's unpack diastolic augmentation first. That's phase 1. The balloon inflates at the dicrotic notch. What happens physically?
So the heart relaxes, diastole begins, the aortic valve closes, boom, the balloon inflates. It occupies, say, 40 or 50 cc's of space in the aorta. It displaces that blood volume.
Right.
And since the aortic valve is closed, that blood can't go back into the ventricle, so it is forced in 2 directions. Distally to the body and, crucially, proximally into the aortic root.
And why do we care so much about the aortic root?
Because that's where the the openings of the coronary arteries are located.
Oh, okay.
You have to remember your basic physiology. The left ventricle is perfused almost entirely during diastole. By inflating the balloon and spiking the pressure in the root during diastole, we massively increase the coronary perfusion pressure, the CPP.
So you're basically force-feeding the heart muscle with oxygenated blood.
You are literally shoving oxygen into the heart muscle while it rests. It's the most efficient way to do it.
So physiologic benefit number 1, increased myocardial oxygen supply.
Correct. And on the waveform, which you should be able to draw, you see a diastolic peak that is often higher than the patient's own systolic pressure. It looks really dramatic.
Okay, now phase 2. Systolic unloading. The balloon deflates just before the heart beats.
Right, so imagine the aorta is pressurized from the balloon inflation. Suddenly, the balloon collapses. This rapid removal of 40 or 50 cc's of volume creates a sudden drop in pressure in the aorta. It's like a vacuum effect, or a sinkhole, if you will.
We'll call that the...
We call this the end diastolic dip.
So when the left ventricle tries to open the aortic valve to eject blood...
It finds the door is already half open. The resistance, or what we call the afterload, is significantly reduced. The left ventricle ejects against lower resistance.
Why is that a good thing?
According to the law of Laplace, reduced afterload means reduced wall tension. And reduced wall tension means reduced myocardial oxygen consumption, or MVO2.
So, physiologic benefit number 2. Decreased myocardial oxygen demand.
Exactly. This is the magic of the IABP. Most drugs, like adrenaline, increase supply, but they also increase demand by whipping the heart. The IABP increases supply while decreasing demand.
It's a win-win for the heart's energy balance.
It is purely beneficial.
And if the student wants to show off a little bit, is there specific ratio or term they should mention?
Yes, you can mention the Buffington ratio. It's the ratio of mean arterial pressure to heart rate, or more technically, the DPTI, diastolic pressure time index, to the TTI, tension time index.
And what did that represent?
Basically, it's a mathematical way of expressing the supply-demand balance. The IABP improves this ratio more effectively than any drug we have.
Moving on to section 4. Indications. This is very high yield. When do we reach for this device?
For this, we look to Miller and Yao and Artuzio for the big 3. Number 1, and the most common, is cardiogenic shock.
Usually following
An acute myocardial infarction, an AMI, or maybe a severe viral myocarditis. The pump has failed, and the drugs aren't enough to support the pressure.
Now, I have to play devil's advocate here. I've read about the IABP SAPP trial. It's famous. It said IABP didn't improve mortality. How should I handle that in the exam?
You must mention it, but with nuance. The examiner will expect you to know it.
Okay.
The IABP SHOCP2 trial did indeed show no mortality benefit for the routine use of IABP in cardiogenic shock. However, in the exam, you phrase it carefully.
How so?
You say, indication, cardiogenic shock. Note, while the landmark IABP SHOCP trial suggests limited mortality benefit in routine uncomplicated cases, it remains a standard modality for temporary hemodynamic stabilization and is widely accepted in exam criteria, particularly as a bridge.
So don't dismiss the device. Just show you're well read.
Exactly. Show you understand the context.
Got it. What's indication number 2?
Weaning from cardiopulmonary bypass, or CPB. This is the classic anesthesia scenario. You are in the cardiac OT, you've done the grafts, you try to come off the pump, but the heart is stunned.
The contractility is poor.
Right, the inotropes are maxed out. You insert the IABP to give the heart a crutch to limp across the finish line. It allows the heart to rest for 24 to 48 hours while that stunning resolves.
And number 3?
Mechanical complications of MI. This is very high yield for exams. We were talking about acute mitral regurgitation or a ventricular septal defect caused by tissue necrosis after a heart attack.
How does it help in mitral regurgitation? That seems less obvious.
Think about the mechanics. In MNR, blood flows backward into the left atrium during systole because it's the path of least resistance.
Right, the afterload in the aorta is high.
Exactly. The IABP reduces aortic afterload with that systolic unloading. It lowers the resistance in a forward path, which is the aorta, so more blood goes out the aorta and less goes back into the atrium.
So it reduces the regurgitant fraction.
Precisely. It doesn't fix the hole, but it improves the forward flow. It acts as a crucial bridge to definitive surgical repair.
That makes perfect sense. Any other indications worth mentioning?
Yes, you can list prophylactic use in high-risk PCI percutaneous coronary intervention or high-risk CIBG. For example, a patient with severe left main disease. It buys you a safety margin during a very risky procedure.
Okay, section 5. This is VivaTrap territory. Contraindications. What stops us from using it?
The absolute number 1, you will fail your exam if you miss this contraindication, is aortic regurgitation. AR.
Why is it so bad? Explain the mechanism. I want to be able to explain this perfectly.
Okay, think about what we just said. The balloon inflates in diastole. In a normal heart, the aortic valve is closed, holding that pressure back from the ventricle.
A closed door.
A closed door. In AR, the valve is incompetent. It's an open, leaky door. If you inflate a balloon in the aorta during diastole, you are driving that blood backward, straight through the leaking valve and blasting it directly into the left ventricle.
So you are actively making the regurgitation worse.
Worse, you are creating a cannon. You will cause acute LV distension, the volume overload will skyrocket, wall stress will go through the roof, and you will essentially kill the failing heart.
You turn the IABP from a life-saving device into
Into a device that pumps blood into the ventricle rather than into the coronaries. It's a disaster.
clear as day. No IABP in AR. What else is an absolute contraindication?
Aortic dissection, absolutely not. You do not want to be inflating a balloon against a dissected flap or, God forbid, expanding a false lumen. You'll rupture the aorta.
Okay, and what about relative contraindications, things to be wary of?
Severe peripheral vascular disease, or PVD. If
Yeah.
the femoral arteries are calcified rocks, you physically can't get the catheter up, or if you force it, you'll occlude the remaining lumen and cause limb ischemia.
Right.
Also, abdominal aortic aneurysms, or AAA, you might dislodge thrombus from the wall of the aneurysm and shower the kidneys or legs with emboli. And severe sepsis is a relative contraindication due to the high risk of infection on the hardware.
Let's talk complications then. What's the most common one?
The most common major complication is limb ischemia. The catheter is large, 7.5 or 8 French. In a small or diseased vessel, that's like putting a cork in a bottle.
So you have to constantly check the leg.
You must monitor distal pulses constantly. Other complications include thrombocytopenia, the balloon physically smashes platelets and hemolysis, and mechanically, the balloon can rupture, causing that gas embolus we talked about, or the catheter can get entrapped.
Section 6, preoperative assessment. The patient has an IABP in situ and is coming for surgery, maybe a non-cardiac surgery, or a return to the OT. What do I check?
First, you verify the indication. Why is it in? Is it for ischemia? If so, keeping the heart rate low is crucial to maximize diastolic time.
And if it's for pump failure?
Then maintaining contractility is key so you know what your physiological goal is. Second, check the hemodynamics. Look at the augmentation ratio on the console. Are they on 1-to-1 support?
Meaning every single beat is assisted.
Correct. If they are on 1-to-1 and barely maintaining a mean arterial pressure of 60, they are incredibly unstable. The induction of anesthesia causes vasodilation. You could crash them on induction. You have to be ready for that.
And the leg.
Always document the leg perfusion. Check the pulses dorsalis pedis and posterior tibial in the limb with the catheter. Check the color, the temperature. If the foot is cold or pale before you start, you have a problem.
And you need to document it.
You need to document that it wasn't your anesthetic that caused the ischemia. It's a medico-legal point.
Finally, anticoagulation.
IABP patients are usually on a heparin infusion to prevent thrombosis on the balloon surface. So you need to check the APTT, or more likely the ACT, the activated clotting time. You need to balance the risk of bleeding during surgery versus the risk of clotting the device.
Section 7. Intraoperative anesthetic considerations. We're in the theater. What changes in my day-to-day management?
The monitor is now your dashboard, and the ECG needs to be clean. The IABP console usually uses the R wave to trigger its cycle.
What about diathermy? The surgeons love their boovie.
That is a huge problem. Electrocautery creates electrical noise. The IABP machine might mistake that noise for an R wave.
So it could trigger at the wrong time.
It could trigger inflation during systole, what looks like an R on T phenomenon on the ECG. This is incredibly dangerous because it inflates the balloon while the heart is trying to squeeze against it. It's like putting a brick wall in front of the ventricle.
So what do?
You communicate. Surgeon, short bursts only, please. Or you can switch the IABP trigger mode on the console to pressure trigger or internal rate during heavy cautery usage. You have to be proactive.
What about arrhythmias? Atrial fibrillation.
AF is the enemy of the IABP. The timing becomes very difficult because the RR interval varies from beat to beat. The machine struggles to predict when diastole will start. The efficacy of the pump can drop by as much as 50%.
And tachycardia.
Also bad. Tachycardia shortens the diastolic time, that's the time the balloon actually has to work and perfuse the coronaries,
Yep.
so you need to control the rate aggressively.
And interpreting the blood pressure. This confuses students because there are suddenly so many peaks on the screen.
Yes, you will effectively see 3 pressure peaks on your arterial line. Number 1 is the unassisted systolic pressure, which is the patient's own weak beat if they're on a 1.2 ratio.
Okay.
Number 2 is the diastolic augmentation from the balloon inflation. This should be the highest peak on the screen if the device is working well.
And the third one?
The third one is the assisted systolic pressure. This is the systolic beat that comes after the balloon has done its work.
And what should that assisted systole look like? This seems like a key point.
It should be lower than the unassisted systole.
Lower. Why?
Because we reduced the afterload, the heart didn't have to generate as much pressure to open the valve and eject blood. If the assisted systole is lower, it is direct proof on your monitor that the device is working.
So that's the Viva question answer. Show me on the screen that the patient is benefiting.
That's it. You point to that lower assisted systolic peak.
What about ventilation and fluids? Any special considerations?
Hemodynamically, the IABP is volume dependent. It works by displacing blood. If the aorta is empty because the patient is hypovolemic, the balloon has nothing to displace, so you have to maintain intravascular volume.
And ventilation.
For ventilation, avoid excessive PEEP if there is coexisting right ventricular failure, as it increases RV afterload. But otherwise, standard protective lung ventilation applies.
Section 8. Post-op and ICU care. Specifically weaning. How do we get this thing out safely?
You don't just pull the plug. That's dangerous. Yao and Artuzio outlines a clear protocol. First, you ensure the patient is hemodynamically stable on minimal inotropes. Then you start reducing the frequency of assistance.
So you go from 1.1.
You go from 1.1, where every beat is assisted, down to 1.2, where every second beat is assisted.
And you watch the hemodynamics closely.
You watch very closely. If they're stable on 1.2, you can try going to 1.3. If they are stable on 1.3 for a few hours and the coagulation is acceptable, you'd stop the heparin a few hours before. Then you can remove it.
Can I just turn it off to standby and leave it in for a day to see if they're okay without it?
Absolutely not. That is a critical error and a huge exam trap.
Why?
The balloon is a large foreign body. If it isn't moving, fibrin and platelets deposit on it very quickly within minutes. You will form a large thrombus on that static balloon.
And when you turn it back on?
You will shower that clot into the brain, the kidneys, the legs. It's a thrombotic catastrophe. Rule: never leave an IABP static in the patient for more than a few minutes. If you have to pause it for transport or something, you must flutter it manually every few minutes to keep it clean.
Got it. Okay, that covers the IABP in good detail. Now we need to shift gears to the big guns. Section 9, ECMO. Extracorporeal membrane oxygenation.
This is a whole other level of complexity. If IABP is a crutch, ECMO is a wheelchair. Or perhaps a stretcher. It's a different game.
So what is it?
ECMO is a modified form of cardiopulmonary bypass, or CPB, but it's used for prolonged support. We're talking days to weeks in the ICU.
What is the fundamental difference between ECMO and the CPB machine used in the cardiac theater? This seems essential for the anesthetist to understand.
It comes down to two main things: time and reservoir.
Okay.
CPB is designed for hours for the duration of surgery. ECMO is designed for weeks. But the mechanical difference is crucial. CPB uses a large venous reservoir. It's an open system. You can dump fluids in. You can suck blood from the surgical field.
Right.
ECMO is a closed circuit. There is no reservoir. The circuit is vein, MUP pump, oxygenator, mater patient. That's it.
Why does that matter for me as an anesthetist managing the patient?
Because it changes how you manage volume. You can't just drain the patient into the machine to fix hypotension from vasodilation, and the pump is very sensitive to preload. If the veins are empty, the pump sucks the walls of the vein shut. We call this chattering or suck down.
Section 10. Types of ECMO. This is core exam knowledge.
Yeah.
VA versus VV.
You must be able to distinguish these clearly. It's the first question they'll ask. Veno-arterial, or VA ECMO, drains blood from a vein and returns it to an artery.
And because it returns to the arterial system.
It bypasses the heart and lungs. Therefore, VA ECMO supports heart and lungs.
And VV.
Veno-venous, or VV ECMO, drains from a vein and returns to a vein, usually from the femoral vein to the internal jugular vein. Because it returns blood to the venous side, that blood still has to go through the patient's own heart and lungs to get to the body.
So it only supports...
It supports the lungs only. It does not support cardiac output. The native heart must be working.
So a simple mnemonic. VA has an A for artery and A for assisting the heart. VV is just vein to vein, just for oxygenation.
That's a perfect way to remember it.
Section 11. Physiology of ECMO. Let's look at the controls. How do we control oxygen and CO2? It's different from a ventilator.
It's actually, in some ways, simpler than a ventilator. You basically have two main knobs to turn.
Okay.
Oxygenation is dependent on the blood flow rate. The more liters per minute of blood you push through the oxygenator, the more hemoglobin you expose to oxygen, and the higher the patient's PO2 will be.
So if my patient is hypoxic on ECMO, I increase the flow.
You turn up the RPMs on the pump to increase the flow. Correct.
And CO2.
CO2 removal is dependent on the sweep gas flow. The sweep gas is the fresh oxygen or air flowing across the membrane oxygenator. CO2 diffuses incredibly easily, much, much faster than oxygen.
So if you increase the sweep gas,
If you turn up the sweep gas flow, which is like turning up the wind blowing across the blood, you blow off more CO2. And critically, this is independent of the blood flow rate.
so just to summarize for an exam answer, hypoxic patient, increased blood flow. Hypercapnic, high CO2 patient, increased sweep gas flow.
Precisely. Now, for VA ECMO physiology, there is a massive concept for the MD exam that you have to know. It's called differential hypoxia,
Also known as...
also known as Harlequin syndrome or north-south syndrome.
This sounds fascinating. Unpack this for the listener. This
Yeah.
feels like one of those aha moments for understanding ECMO.
It is. Imagine a patient on peripheral VA ECMO. You're draining blue deoxygenated blood from the femoral vein and pumping red oxygenated blood back into the femoral artery. That oxygenated blood shoots up the aorta. It's retrograde flow.
Right, so the legs, the kidneys, the abdomen are all getting this lovely oxygenated blood from the ECMO circuit.
Exactly. But the patient's own heart might still be beating a little bit. It's still ejecting blood from the lungs.
And if the lungs are terrible.
If the lungs are terrible, like in severe ARDS or pneumonia, the blood coming from the heart is deoxygenated. It's blue blood.
So we have red blood coming up from the legs from the ECMO circuit and blue blood coming down from the heart.
Exactly. They meet somewhere in the aorta. We call this the mixing cloud. The danger is when the heart starts to recover a bit and pump stronger. That mixing cloud gets pushed further down the aorta.
And what's the problem with that?
The problem is that the heart is now pumping that blue deoxygenated blood into the aortic arch. And the first branches of the arch are the innominate artery, which feeds the right arm and right carotid artery, and the left carotid artery.
So the brain and the right arm receive the blue blood from the failing lungs.
Yes. While the ECMO perfuses the liver, kidneys, and legs with beautiful pink oxygenated blood.
So the patient literally has pink feet and a blue brain.
Correct. That is north-south syndrome. The north, the head is hypoxic. The south, the legs is hyperoxic. This is a recipe for a cerebral hypoxia disaster if you don't detect it.
Section 12, indications. Who gets which type of ECMO?
Okay, VA indications. First, cardiogenic shock that is refractory to IABP and maximal inotropes. Second, failure to wean from CPB, so post-cardiotomy shock.
And the third one, ECPR.
And the third big one is ECPR, extracorporeal cardiopulmonary resuscitation. This is a hot topic. Miller quotes survival rates of around 29% for ECMO initiated during cardiac arrest, which is significantly better than conventional CPR for prolonged arrests.
VV indications.
VV indications are for pure respiratory failure. Severe ARDS COVID pneumonia was a big driver for this. Refractory hypoxemia with the PF ratio less than 80 despite proning and paralysis. Or it can be used as a bridge to lung transplant.
Section 13, complications. What goes wrong on ECMO? Seems like a lot could.
Bleeding is the number one enemy, the number one complication. You have to systemically heparinize the patient to stop the circuit from clotting, but the circuit also chews up platelets. It's a consumptive coagulopathy.
So you're walking a tightrope.
A very delicate balance. Intracranial hemorrhage is the most feared bleeding complication and often what limits survival.
What else?
Thromboembolism. Clots can form in the circuit, especially in the oxygenator, and then get shot into the patient. In VA ECMO, that's a stroke. In VV ECMO, it's a massive pulmonary embolism.
And the leg again.
Yeah.
Just like with IABP.
Yes. Limb ischemia in peripheral VA ECMO is a huge issue. You put a huge cannula, we're talking 17 or 19 French, into the femoral artery. It essentially plugs the vessel. The leg distal, to that point, will die.
So how do we fix that? This must be an important exam point.
It is. You must mention this. You place a distal perfusion catheter, often called a backflow cannula. It's a small line that's tapped off the main arterial return tubing and directs blood down the leg to perfuse the foot.
And if you don't mention that in your answer,
the examiner will assume you're going to let the patient's leg get amputated. It's a critical part of the management.
Section 14, preoperative assessment in ECMO. If an ECMO patient comes to the OR, what are my top priorities?
First, type. Is it VA or VV? This is the most important question. If it's VV, you have to remember the heart is on its own. If they get hypotensive, you need inotropes or fluids. The ECMO won't fix the blood pressure.
And if it's VA?
If it's VA, the ECMO is the blood pressure. Managing the flow rate is managing the cardiac output.
Next, check the lines.
Cannulation site stability is vital. These are huge cannulas. If one gets dislodged, it is an immediate, catastrophic, fatal hemorrhage. Check the coagulation. What is the ACT target? Usually it's between 160 and 200 seconds. And check end organ status. Are the kidneys already failing? Are they on dialysis or CRRT as well?
Section 15. Intraoperative anesthetic goals. This is very high yield. What do I need to achieve?
Preload is king. I can't stress this enough. ECMO pumps are centrifugal. They are preload dependent. If the patient gets dry from bleeding or vasodilation from anesthetic drugs, the vein collapses around the drainage cannula.
And that's the chattering you mentioned.
That's the chattering or kicking you'll see. The lines will shake violently. This is sucked down.
What do you do when you see that?
Give volume immediately, blood, crystalloid, whatever you have. Or you can decrease the pump speed temporarily to let the venous system refill. Do not ignore it, or you will cause massive hemolysis and risk entraining error.
What about afterload?
In VA ECMO, high afterload is a big problem. Remember, the patient's own LV is trying to pump against the retrograde flow from the ECMO machine.
So you're creating a fight.
Exactly. You want to maintain a mean arterial pressure of 60 to 80 millimeters of mercury. Too high, and the LV can't open the aortic valve at all. That leads to stasis and thrombosis in the aortic root.
And ventilation. What are the ventilator settings?
The lungs are being supported by the ECMO. You don't need to blast them with high pressures. The goal is lung rest.
What does that mean in practice?
Very low tidal volumes, what we call ultra-protective ventilation, maybe 3 to 4 milliliters per kilogram, a low respiratory rate, maybe 10 breaths per minute. But you use high PEEP to keep the alveoli open and prevent atelectasis. The goal is to prevent ventilator-induced lung injury, or VILI.
Section 16, monitoring. We talked about north-south syndrome. How do we actually monitor for it?
In peripheral VA ECMO, you absolutely must have a pulse oximeter on the right hand.
Why the right hand specifically, not the left?
Because the right subclavian artery, which supplies the right arm, is the first major branch off the innominate artery. It reflects the blood composition in the aortic arch, the same blood that's going to the brain via the carotids.
So the right hand is a surrogate for the brain.
It's the best surrogate we have.
Yeah.
If the right hand sats are low, say 85%, it means the brain is getting hypoxic blood from the failing lungs, even if the pulse oximeter on the foot is reading 100%.
And arterial lines.
Ideally, you place the arterial line in the right radial artery to match the SpO2. This gives you the true cerebral perfusion pressure and allows you to sample blood gas from the native circulation.
And I should be aware that the waveform might look different.
Yes. In full VA support, the arterial line might look flat. It will be non-pulsatile. In that case, you treat the MAP, not the systolic pressure.
Section 17, the comparison. IABP versus ECMO. The examiner asks you to compare them side by side. Let's create a mental table for the listener.
Okay, let's do it. First, mechanism. IABP is counterpulsation. It's an augmentation device. ECMO is bypass. It's a replacement device.
Good distinction. What about heart support?
IABP provides partial cardiac support. It requires some native heart function to work. VA ECMO provides full cardiac support. It can work even with a heart that's at a complete standstill.
And lung support.
IABP provides none. ECMO, both VV and VA, can provide full respiratory support. IABP is relatively simple. It's usually placed percutaneously at the bedside or in the cath lab. ECMO is a highly complex circuit that requires a trained perfusionist and a dedicated team. It's much higher risk.
And then finally, cost and labor.
ECMO is significantly orders of magnitude more expensive and labor-intensive than an IABP.
Section 18, role of the anesthesiologist. Let's summarize. Why is this our job?
We are often the team leaders in these situations. We use our skills in transesophageal echocardiography, or TE, to guide the placement of the cannulas. We're the ones who can diagnose complications like annula malposition or cardiac tamponade in real time.
And we manage transport and crises.
Exactly. Moving an ECMO patient to the CT scanner is a military-style operation that we often lead. And when a crisis happens, if the circuit fails or a line is accidentally pulled, we are the ones at the head of the bed managing the massive hemorrhage and the cardiac arrest that follows.
Section 19, common exam questions and viva traps. Let's save the student from failing. What are the common mistakes?
Trap number 1, confusing VA and VV. They will ask you to trace the lines. If the return cannula goes to an artery, it's VA. If it goes to a vein, it's VV. You must know this.
Okay, what's strat number 2?
Treating ECMO like CPB. Remember, ECMO has no venous reservoir. You cannot just drain volume out of the patient quickly to treat hypertension. It doesn't work that way.
Trap number 3.
Ignoring the leg and IABP. An examiner will fail you if you don't mention checking distal pulses and monitoring for limb ischemia. It's a critical safety check.
And the last one.
Timing errors for the IABP. They'll show you a waveform and ask you to identify if it's early or late inflation. Inflation before the dicrotic notch, early inflation, is dangerous. It increases the stress on the heart. You must know what that looks like.
Section 20, diagrams and exam presentation. What should they draw on the paper to get top marks?
You need 2, maybe 3 simple diagrams. First, the IABP waveform. Draw the unassisted beat, then draw the assisted beat right next to it. Show that the diastolic peak is higher than the systolic and the end diastolic pressure is lower. And you must label the dicrotic notch.
And for ECMO?
A VA versus VV schematic, just a simple stick figure. For VA, draw a line showing blood leaves the femoral vein and enters the femoral artery. For VV, show blood leaves the femoral vein and enters the jugular vein. Keep it simple, but label the flow directions clearly. It shows you understand the fundamental difference.
Section 21, summary and exam conclusion. Let's wrap up with the final high-yield take-home points for the exam hall.
Okay, here's the rapid-fire recap.
IABP increases supply through diastolic augmentation and decreases demand through systolic unloading.
2.
Timing is key. Inflation at the dicrotic notch, deflation just before systole.
3.
The absolute contraindication for IABP is aortic regurgitation.
A FOMO.
VA is for heart and lung support. VV is for lung support only. ECMO physiology. Blood flow controls oxygenation. Sweep gas flow controls CO2 removal.
6.
The biggest complications for ECMO are bleeding and, for VA ECMO, limb ischemia.
And 7.
Monitoring. Always use a right-hand SpO2 for peripheral VA ECMO to detect Harlequin syndrome.
And the final sentence for a long answer, a model conclusion.
Your concluding paragraph should be something like this. In conclusion, mechanical circulatory support has revolutionized the management of refractory cardiopulmonary shock. The anesthesiologist plays a pivotal role in the insertion, maintenance, and weaning of these devices, requiring a deep, integrated understanding of the art and physiology to ensure patient safety and optimize outcomes.
Fantastic. That was a marathon session, but absolutely packed with high-yield information. Thank you so much for that masterclass.
My pleasure. Go draw those diagrams and practice explaining the waveforms. You'll do great.
To our listeners, good luck with your MD exams. You have the knowledge, now go ace it. And for some extra reading, check the Miller chapter on extracorporeal support for all the fine print. We'll see you on the next Deep Dive.